many of you are appearing 4th April? So you have only exactly 1 month in your hand.
Yes, sir. I am
So how
appearing
many
for
of
this
you are appearing?
for this April exam.
This April?
Yes, sir.
Okay. So remember we have chosen our faculty in such a way. So Deepak, we have done our part 1 today.
Yes,
the
sir.
part 1 crash course. So I'm just saying to them regarding the last minute tips. Deepak, you have done your EDIC. You are taking classes for EDIC for quite a long time. You just give some words to them how they will utilize this last 30 days.
Yes, sir. I have actually in my lecture itself yesterday, most of you must be present. I already told the tips and tricks, whatever I have. I think EDIC one more of a kind, it's you have to give your time. Last 30 days, it's a very important. The more MCQs you do, see one thing that day also I told you yesterday, for solving the MCQs, maximum MCQs if you solve, then only you will be able to solve the MCQs. Theory ऐसे बैठ के पढ़ने से continuously कुछ नहीं होगा. You have to solve maximum MCQs, mostly from the ACE modules, then from so many books. I have already, yesterday I have shown you the books and all the tips and tricks I have told you. You have to give time in this last phase. Then only you will be able to pass EDIC 1. The more time you give, the more chances you have. It's quite less regarding your knowledge and everything. It's the hard work which you'll get through EDIC 1. For EDIC 2, you need talent and how much you see the patients and how you manage the patient, that matters. In EDIC 1, it's purely quite hard work.
So Priyatos, what is your feeling about our course? You have seen 15 different faculty.
I know most of the you faculties, but I was not knowing this Farz Academy. So I came to know you, but only 1 week earlier, and then I joined this crash course. My only aim is to like just what you were telling the last 30 days utilize because I'm too busy in my ICU, sir. Almost 10 to 12 hours per day in ICU. And then remaining time I have to prepare. So I am just focusing on Bennington and Lobas. So this will be enough, or I need to do something else also.
You for this last 30 days, you practice MCQ wherever you get the MCQ, you can practice. Just don't focus on the theory. Now you practice in the MCQ because while you are doing MCQ, you will have an idea what exactly the question stem itself will give you the clue that what exactly the examiner wants to know.
Dr. Stosh has also joined. Sir can give some tips.
Yeah. So any other student, please switch on your video. This is the last session, interactive session, that if you have any queries, you can ask. Our eminent faculty is here. Asutosh is very senior consultant. He did his EDIC long days ago, but he is continuous with the EDIC preparatory course with Farz Academy, and he is a very good teacher, as you all have seen, and he has a very good depth of knowledge.
So I have a doubt about
Yeah, you switch on your video, ma'am.
Okay.
Yeah,
okay.
come.
I'm here.
Yes.
Hi everyone.
Yeah.
So I have a doubt regarding negative markings. There's a huge confusion regarding it. Do we have negative markings in EDIC?
Negative marking, no, there is no negative marking in EDIC exam, but remember that the marking in A-type question, if you write, then you will get 4. In K-type question, if the 4th thing is right, in true false, 4th thing is right, you will get 4. If 3 thing is right, you will get 2. If 2 thing is right, you will get 0. So you have to do a 3 right answer.
Thank you, sir.
And Silpa, Shruti, anyone? You please switch on your video and you come forward, you ask question.
So
Yes,
also,
Silpa.
for you guys
Yeah.
could just highlight on the mechanical ventilation, major points of bronchial asthma and COPD. Highlight points about it, because it's always a little confusing about pressure mode, volume mode, and sometimes both of them have the same setting. Sometimes we don't know how to approach them because of his pathophysiology. If you could give us pointers.
Asutosh?
Yeah, for mechanical ventilation in COPD, asthma, and ARDS, yeah, there is a very good table given in the Washington manual. They have given the settings, they have given that how much PEEP should be there, what is the IE ratio, what is the tidal volume. So for your understanding, the important thing, if you are ventilating a patient with COPD, the most important thing is the IE ratio. So you have to keep the IE ratio in an established case of COPD 1:4 or 1:5 to prevent the auto PEEP, because there is a high possibility of auto PEEP. So, and the most important thing is auto PEEP is a side effect of the mechanical ventilation. So in any case, it is not like that auto PEEP is only in COPD patient. It may occur in any situation in which you increase the respiratory rate to more than 24. So 24 is an arbitrary figure. It is not a truth, but the important thing is that when you increase the respiratory rate to more than 24 or more than 26, whatever, there is a less time for the expiration. If expiratory time is less, then definitely there will the volume retention in the lungs, in alveoli, and that will cause the auto PEEP. And if you are getting the auto PEEP, you can understand by the flow time scalar. Among three scalar, pressure time scalar, volume time scalar, and flow time scalar, with the scalar which goes in negative side is the flow time scalar. So you can understand which is flow time scalar. And if in the flow time scalar, the expiratory limb is not touching the baseline, then it's a auto PEEP. And for calculation of auto PEEP, you have to put a expiratory hold. By the expiratory hold, you will get the total PEEP. Then you will do total PEEP minus set PEEP. Suppose you have set PEEP is 6 and total PEEP is 14. So auto PEEP is 8. 14 minus 6, 8. And set PEEP should be 80% of the intrinsic PEEP or auto PEEP.
Correct.
So if auto PEEP is much larger, then you have to increase the set PEEP. But this is the last resort. For auto PEEP correction, you need, first of all, you have to decrease the respiratory rate, then decrease the tidal volume, then increase the flow. By increasing the flow, you are basically decreasing the inspiratory time. It means you are increasing the expiratory time. So these are 4 or 5 strategies for the correction of the auto PEEP.
So Asutosh, Silpa, both of you, that if you have any doubt, we will take a special class before the exam. So you can put your queries in the group. So our examiner all are ready to help you out. This 30-day, the group will remain open. So whenever you feel any doubt or any difficulties, you can put the question in the group and we will help you out.
Yeah,
Okay.
respiratory, actually, I had put a few questions, 3 questions were there on this dynamic hyperinflation. Because these are some of the favorite topics of EDIC in COPD patients. I have explained all these things in detail.
Correct. So sometimes both the pathophysiologies will still be the same.
Yeah, almost the same.
You cannot say you need to follow only volume controlled or pressure controlled.
No, mode, always it is said, mode is not important. You can start with any mode. It is clearly written. It is not ki volume control say start karna hai pressure. You can start with any mode.
Okay.
That is not an issue.
Okay. Thank you.
And in exam questions, they ask any mortality benefit with any particular mode. There is no mortality benefit with any mode in any situation.
Okay.
So mode is
So you
basically
will get
it's your
question
choice.
on that. Is there any mortality benefit of pressure control or volume control? So choice is no.
Okay.
Yes.
So,
Any
So thank
question
I
you can ask in
think
group also.
RRT prescription, I think about the flow rates and everything, it's a little confusing. How do we prescribe apart from the exam
Yeah,
point of view?
RRT, the
So,
prescription writing and the things is a little bit complicated,
complicated.
but
Yeah.
the question always come regarding the prescription writing. Okay. So this part you have to understand. And if you have any query, you put your query. Dr. Ronojit is the best person regarding the how will do prescription writing. He will help you out. Don't worry.
Okay, sir. Thank you.
For basic understanding, I will do one or two things quickly. For prescription writing, basically you need to calculate the dose. And the dose of CRRT is 25 to 30 ml per kg. It's an effluent. Effluent means waste, which comes the bag in which comes all the food. And if you are CVV HDF, you are using CVV HDF, it means you are using both dialysate as well as replacement fluid.
You have to
I already told in one of my lecture that CVV means dialysate, CVV means replacement, CVV HDF means both dialysate and replacement. SCUF, no dialysate, no replacement. So very simple. First of all, you need how many bags you have to put in the CRRT. One bag CVVHD, only dialysate. 2 bags CVVHD as well as replacement. It means CVVHDF. Obviously, there will be pre-filter blood and the effluent. So overall 4 bags will be required. But in CVVHD, you need not replacement fluid. CVVHDF, you need both fluids. So if the diagnosis is dose is 25 to 30 ml per kg and patient weight is 70 kg, it means it is a 2100. So you have to divide these two things into the blood flow as well as replacement fluid. Sometimes we consider 1200 ml per minute is the blood flow and 1000 is for the replacement. And replacement is divided into 30-70, 2/3, 1/3, depending on the situation.
Okay.
So basically, prescription writing is depend on which mode you are using, which fluid you are using, and roughly we use blood flow in 1000 or to 1200 ml per minute. We can take a separate class on the CRRT or some basically, Dada Asif, do one thing, collect some questions or some topics, and we take a class which includes all their doubts, a special class.
Yes.
Which include 8 to 10 topics.
So see,
we can take a doubt clearing class, correct?
Yeah, you all can put your doubt regarding the any chapters. There are 15 domain we have completed last 2 days. So whatever the doubt you have, we will take a special class before the exam.
Yes.
Those who are exam going student, and those who are not giving the exam, I will request all of them to join our regular courses where me, Asutosh, Deepak will be there, and we take regular classes where we can clear they have time, so they can do better in the next exam. So thank you all. If
I have one request that these 500 questions PPT should be provided to us, sir. Because
you will get this thing in our portal, and this portal will be open for till 4th of April exam. Okay, so don't worry, you will get.
Okay, thank you, sir.
Okay, anyone want to share his or her thought, or you have any other doubts? Otherwise we will close the session.
So how you feel in last 2 days, today and yesterday? How you feel? What is your preparation and what you want extra?
I came with so many new questions. Particularly today's AKI session was ultimate. Like it has too many new things was there. Last session of infectious disease, ABG session was also very good. Today's session, actually, I had a night duty yesterday, and now I am doing this continuous whole day preparation. So today's session I have enjoyed a lot because too many new concepts I found here.
Thank you, Asutosh. Thank you,
Thank
Deepak.
you.
And Asutosh is,
Okay,
you have spent whole day since morning you are there. And thank you, Deepak, also.
Okay, sir.
And we will do our EDIC preparatory for part 2 in the April 15th. So we will do another meeting with all faculty. Will do meeting and we'll plan accordingly. Thank you.
Thank you.